Yes, we can start. Marsh, you can give heads up.
Okay, sir. Okay, sir, we are going live in 5 seconds. 5, 4, 3, 2, 1. Sir, we are live now.
Okay, thank you very much. Good morning, all of you. So we are starting this pediatric trauma module of lower limb fractures. And I will ask Chinmay and Kaisar to take over from here.
Sure.
Thank you.
Thank you so much. Thank you so much, sir. I'll just share my screen, sir. Good morning, everyone, and welcome to the Orthokids trauma module for this week. So we are starting the trauma week or a trauma month this month, which is followed by the technical videos and long-term follows. And we are mostly involving all the pediatric orthopedic surgeons all over the India. So today we have Dr. Chintan Doshi, who is a young and dynamic pediatric orthopedic surgeon who is working in Mumbai. Health Sciences. For further consolidation of his pediatric orthopedic practice, sir went to the USA and Singapore, where he done pediatric and adolescent orthopedics. At the same time, do a extensive fellowship in pediatric sports medicine. Sir also is a possible K. Wilkins Traveling Fellowship holder. And sir is also visiting expert at Shriners Hospital and Market University. And sir is practicing since last 4 to 5 years in Mumbai as an individual and solely pediatric orthopedic surgeon. Over to you, sir. Thank you.
Hi, good morning, everyone.
Morning, sir.
So thank you for that very generous introduction. So I'll today take a presentation on management of femur shaft fractures in different age groups. I'm pediatric orthopedic surgeon from Mumbai. So just let me start my screen. Can you see my screen?
Yes, sir.
Yeah. So so today we are going to discuss on the management of femur shaft fractures in this particular age group. So we'll include birth injuries, neonatal fractures, or fractures in kids less than 1 year when they're not walking. We'll include them from 1 to 5 years, see how they're managed, and then further on from 6 to 12 years in different scenarios, and also the adolescent fractures just before maturity. So birth and neonatal fractures are very common during difficult delivery, or there's while delivering the baby. And we are often presented with this type of scenarios. We get a call from NICU or from a maternity home saying that the child is not moving the limb and there's swelling on the thigh. And we get the X-ray and we see such fractures. So these look nasty. And the most important part of managing this is managing the parents. All of us know this is going to heal well, it's going to be fine. It is the counseling and the initial anxiety of the parents, which is the most important thing to tackle during this period, because the medico-legal involvement is during that time. It is not the fracture healing, it is not anything else, but those things. How did my child get this fracture? And that is how we have to deal with it initially. So we have following options from the literature. We know that brand traction as an age-old method does well. Strapping is also described. Paulic harness, very few centers do any spica for this, but it's not very well recommended. And if any one of you have anything else that you do, you may share with us so that we also know about it. So this now, even to get this picture, we don't get to see this in our wards now. So I had to look into a books, and even that is in black and white. I couldn't get a color picture as well. So these kind of brand traction or gallows traction are now outdated, but still can be followed if, let's say, if we have a situation where the child is in the hospital and we need to give traction for a little longer period. This can be done, but we have better modalities to now treat these fractures, and they also do pretty well. Strapping, so it is followed, tying the leg to the thigh or thigh to the chest wall. I've never done that. I've never tied the thigh to the chest wall, but to the abdomen, but it is described. Other thing that I do in strapping for the initial management till the time we get any definitive Paulic harness or of the particular size in a specifically in a preterm or a very low birth weight baby. What I do is use a tongue depressor or wooden tongue depressor, nicely padded with a gamgee roll, and just give it a 90 degree of knee flexion just to support the thigh so that the child is at ease. It is all about relieving the pain and the discomfort to the child. So it is just immobilizing in this period, in the initial period of fracture. Later on, definitely, as we had our top poll options, we have seen many of us of these will prefer Paulic harness, and it is the right modality as per the literature. But those interiors or those places where the Paulic harness is not readily available or needs to be made, it takes few days. Initial splinting and strapping will definitely help. So management in Paulic harness. So this similar, the same case which was for poll opinion, we have managed with Paulic harness, and we have seen that in long-term follow-up, even though there is malunion at 2-3 months, but eventually it completely models and the child has no problems when he reaches the walking age. So when the child is about to walk, almost all of the deformities are corrected. There could be some residual deformity, but then still it would be not hampering any gait, causing any gait abnormality to the child. So Paulic harness, as we know, the first 4 cases that I described here, all of them treated in Paulic harness and all of them have done well. So literature also supports Paulic harness. There's literature from China, there's literature from Europe, US, everywhere where they've compared Paulic harness with Bryant traction or Paulic harness with strapping, and Paulic harness does well for globally. So everywhere Paulic harness has been recommended as a treatment of choice. However, when there is difficulty in getting a harness, we can start with strapping initially. So this case of Dr. Tushar Agarwal shows a long-term follow-up when the child starts walking, and it is pretty decent. There is no gait abnormality. And Paulic harness has been initially described from 1995, and it provides us the best alternative so far. So where does this work? So it works for all the birth injuries causing femur shaft fractures or proximal third femur fractures. It is helpful in neonatal fractures, which is caused due to massaging or harsh handling and or maybe fall from the bed, turn, roll over. It will help in those cases as well in infants up to 6 months. In very low birth weight babies where the Paulic harness still fits the child, it can also be extended up to 9 months to 1 year of age. Now coming to our toddler age group from 1 to 5 years, when the child is walking and it is not possible to control the child in the Paulic harness itself, child start crawling and walking and doing all sorts of things, we have better modalities. So treating this toddler fracture of 18-month-old kid with middle third femur shaft fracture, this was treated in a hip spica cast, and again at fracture healing, approximately about 4 to 6 weeks from the fracture, we take a check X-ray, see the callus, and then plan to remove the spica. Another toddler, so this was again our poll option, a 4-year-old with distal third femur fracture. Most of us have preferred spica, and it is the right modality of treatment because up to 4 to 5 years, indication for tensional is not even recommended in the literature. There are some papers from Europe, but then it is better. These are treated in conservatively as they remodel well, and everything is going to go fine as the fracture heals. So this was treated in hip spica cast. I try to make my spica more interesting, giving animal prints or this kind of. So I don't need a bar in between with difficulty in changing diapers or anything. But if only POP cast is given, then bar connecting the 2 legs is important. This shows a 10 weeks follow with very, very good remodeling in this case. So when we are discussing spica, let's discuss if there is any particular position in which the spica is given, or we need repeated check X-rays maybe every week or so on follow-up. So position, if we have to decide, then it depends on the muscle forces acting on the fragments. So if it is a very proximal third fracture, a 30-30-30 spica would do well. 30 degree of abduction, 30 degree of flexion, 30 to 40 degrees of flexion, and about the neutral rotation. So, but if it is a middle shaft fracture, mid shaft or a lower shaft fracture, lower third fracture, it's not mandatory to give in 30-30-30. It could be given in a bit of more of hip extension, so that child is sleeping comfortably, and an older child that would be preferred. Follow-up X-rays, usually I take one X-ray at 15 days to see if the alignment, because there will be reduction in swelling, and there may be some bayonet or there may be some loss of reduction. Still, I have to just check whether it is acceptable and it is okay, or there is no need for any remanipulation. And then again, a check X-ray is taken when we plan to remove the spica to see the callus. So, shaft femur fracture in less than 5-year-old, as we saw, spica works well. Getting a good alignment and acceptable reduction is important. It need not be perfect anatomical, but just get a straight alignment. It need not be in more than 30 degree of varus or so. So, because then it will take a long time to remodel, and then the gait abnormality will start manifesting once the spica is removed. So, literature on hip spica in a femur shaft fracture in a toddler age group, there is a systematic review which has given us a lot of things to look into. So, complication rates, there are basically no complication. If you see, the maximum complication is for the skin here, about 8%, and that is because of poorly managed spica, or urine or stool soaking into the spica and causing skin ulcerations or irritations. Other manifestations are very, very rare. So shortening is just about 1 to 2%. Angulation is about 4%. And really, the one which is very, very much worrying is peroneal nerve palsy. Maybe because of poor application of spica, out of 1,700 cases, only one patient had it. So if it is upright properly, the chances of getting any of these would be very less. So we talked about acceptability criteria while getting acceptable reduction. So what are the acceptability criteria? So in this age group, about 1.5 to 2 mm of shortening is very well accepted, and it's going to get better as the healing and remodeling happens. Closer to adolescent age group, beyond 10 to 12 years, the shortening accepted is very less. It may be 1 to 1.5 centimeters, not up to 2 like how it is accepted below 5 years of age. And angulation again depends on the age. About 15 to 20 degrees of angulation is very well tolerated because it will remodel quickly in an early age group, less than 5 years. But going beyond 5 years, it is better to get a good varus valgus alignment, or even flexion extension to prevent any procurvatum. So then we speak about single leg spica. So we single leg spica, I would prefer basically in undisplaced or minimally displaced fracture, where there is not much of bayonet, there is not much of overlap, and it's going to be stable in a single leg spica. So if there is overlap of more than 1.5 to 2 centimeters and we need to maintain reduction, it is always better to get a 1.5 spica, so as to get a good control in the pelvis, and there is no loss of reduction when this is applied. So as we already discussed, in this age group, usually titanium elastic nailing is not preferred, and but there are some literature where they have shown, and this is mainly European. Both of these articles have come from Europe. It is a little overdue in my say, but yes, there are some specific indications in which we would do tense nail in less than 5 years of age, associated with a neck fracture or associated with hip dislocation. If you want, if there is other injuries which are going to have an effect and which will need any intervention, then it could be done to stabilize both of them at the same time. But otherwise, it is not very much indicated. So then we go on to the next age group above 5 years, so 6 to 12 years of age group, and this is one of the fracture where we have too many options to do. We can conserve it, we can do spica again, or the traditional method of tense nailing would work well. So we divide this age group into special scenarios and the regular just a mid-shaft fracture with transverse or low oblique fractures. And the stable fractures, transverse, low oblique, single fragment would go on well with tense nailing, and it would go on to heal very well. So this technique is going to be described now again by our friend after my talk. So tense nailing does well. I would specifically point out in the use of this reduction tool. F tool is available in tense nail set, and it is a very handy tool to get the reduction, maintain the reduction when the tensile are being passed. So it's again a post-op X-ray of a similar patient, which shows a good healing at 3 weeks. Already a callus has started forming, and then further going to heal nicely. The different scenarios that we are going to discuss in this age group are where it can be a different modality of treatment, or where we have to be a little caution rather than just using a single modality of tense nail. So here, now this was again our poll option in the today's morning brainstorming. A 10-year-old boy fell with while cycling and got this nasty fracture. A long spiral with a butterfly fragment as a third fragment. This looks clearly looks unstable, maintaining the length, because the third fragment is almost 1/3 of the shaft, and it is involving more than 50% of the circumference as well. So whether this would just work with tense nail, it would, but tense nail would back out if there is a loading, and if the child starts walking early, or if there is any regress movement, then the tensile may back out before the callus is formed. So as per our poll options, yes, tense nail plus X-fix was more preferred. However, I would say others are not that they cannot be done. So in a situation where patient cannot undergo a surgery or is difficult, spica cast can be done, very well fitting, good maintenance. It can be done, but if everything goes well, then it is better to fix it. Again, tense nailing, purely tense nailing would not do its job, because as we said, it's length unstable. Something hybrid, something along with complementing tense nail would do, like a X-fix, casting, or others. Submuscular plating also is an option and is valid option. There is if you are trained well and you're okay to do it without opening the fracture site, then yes, it would work well. So what we did here was a tensioner and X-fix, as the most of our poll suggested. So basically, here we put tense nail to maintain the alignment, and external fixator is only for the initial period till the time the soft callus is found, and we see some callus or bony union on the X-ray, which will be about 4 to 5 weeks. In a month's time, we remove the external fixator because we want range of motion. We don't want that those wires sticking out, because we have tense nail inside to hold it in place. It is only to maintain the length till the time the initial healing phase has occurred. So at 4 weeks, we did remove the fixator. Here you can see the fixator holes and everything, and a good bone-to-bone union. Soft callus still, it is not completely remodeled bone yet, but it is good enough to maintain it with only tense nail now. It may not collapse any further. So at 2 months, it shows good healing, and then this is the clinical video and the way the child can sit. There is a lot of apprehension in using external fixator. There would be knee stiffness, but what my take is, if you do physiotherapy right from the first day, you allow child to move knee, yourself you see that entire knee range of motion is possible when the fixator is still on, then the results are pretty good. You need not keep him stiff and immobilized. Otherwise, knee range of motion can be started on almost immediately. So a similar patient, again, an external fixator done for this middle third butterfly, long spiral butterfly fragment. Again, went on to heal very nicely. This is 1 year follow-up, and again, this kid after tensile removal has pretty much of a good function. Another special scenario we're going to discuss is when the fracture site is away from the mid shaft, it is closer to the physis. So here we see the fracture line is almost 2 centimeters from the physial distal physis. And here tense nail will be very difficult to negotiate. One, second, to maintain the reduction. So in such cases, I prefer to use a sliding plate or a bridge plate where not the fracture site is not open. It is the plate is just slided from the distal end, distal metaphysis onto the proximal metaphysis, and it is just done in a percutaneous method. The fracture is just aligned normally in both anteroposterior and lateral planes so as to not cause any major deformity. But otherwise, it goes on to heal well, and again, remodeling is good in these cases, even if some amount of deformity is persistent. So in these special scenarios where it is length unstable, external fixator versus plate, both of them have shown good results. We have our own literature from Mumbai, our team from Mumbai, where they have compared tense nail with external
Chintan, we cannot hear you. Can you all hear Chintan well?
No.
No, sir.
No, sir.
So I think Chintan's computer stopped there. So let's wait for a moment. He might be reconnecting. Because unless he stops sharing, yeah, so he has, I think he would rejoin in a moment. So by the time he rejoins, a few points I would like to make. One, in a birth trauma, it's not very good idea to do stripping in any position because the skin is so soft. And we have seen a lot of skin complications with adhesive strapping. Some people have tried to apply just the micropore, but by the time the harness comes, it's very easy to just position the foot in least painful situation. The another point is about the hip spica application. The valgus.
Yeah.
Yeah, Chintan, you can restart your presentation.
Sorry, sir, I lost connection.
That's not a problem. So when we apply spica, valgus is well tolerated and not the varus. So always give a valgus mold when you apply spica from your shop. Yeah, Chintan, you can start.
Yeah, so I don't know whether this was covered, the literature on tense nail with fixator versus plate. Was this covered, sir, already? I don't know whether.
Yeah, this slide was there. Yeah.
Okay. Yeah. So, so the next slide. Yeah. So the consensus on treating this kind of older age group children from 6 to 12 years in a diaphyseal fracture, tense nailing works best. Submuscular plating is also accepted. However, in length unstable, only a tense nail would need something additional, maybe a hybrid fixation, maybe a hybrid tensile with a cast, or a submuscular plating. In a pathological fracture like what Dr. Maulin Shah sir discussed in the morning, if it's Australian imperfecta, intramedullary nail would work better. Or in fibrous dysplasia, again, intramedullary nail will be a better choice of implant rather than a plate. So in a pathological fracture, always intramedullary nailing is better, but it depends on what the pathology is and where the pathology is. If it's in the neck, again, if it's a cyst in the neck, then we will need some kind of a plate to hold the proximal femur in valgus and maintain the thing with the locking screws as well. So it depends on the pathology and the location of the fracture, but more or less intramedullary nailing for shaft femur fractures in a pathological fracture would do well. If it is a metaphyseal fracture, where the fracture is closer to either physis, above the lesser trochanter or very close to the distal physis, as we discussed in the previous case, a plating will be a preferred option rather than tense nail, because tense nail won't be able to hold the fracture in proper position, because then the amount of nail beyond the fracture would not be sufficient enough. So another age group that we have to discuss is when the child is nearing maturity and around adolescent age group. So nearing maturity, we can use again if the child is less than a low weight boy or a girl, then we could do a tense nail in weight less than 50 kgs. A bridging plate is also a good option. However, we have more options open now. As the physis is about to close, we can use a nail which goes through the physis from greater trochanteric entry nail, adolescent femur nail, or a humerus nail from the greater trochanter. So here I discuss a case of 14-year-old female where almost all the physes have been fused. This girl landed on while skydiving and injured her thigh bone, and this was what we had done. So this was the first adolescent nail we used in Singapore, and I was fortunate enough to be present there and use it with the team there when it was first sanctioned in 2017 at Singapore Hospital. So if you see here, it rather than our traditional PFN or long femur nail, here the adolescent femur nail has entry beyond greater trochanter. It is beyond the tip of greater trochanter on the lateral side, because the curvature of the nail there is pretty much going away from the physis towards the lateral cortex, and this would do well in cases even if the trochanteric physis is just about to fuse, because there's not much growth remaining. So this is what we had done, and unfortunately I finished my fellowship about 3 weeks after this case, and then I did not have a full follow-up with clinical photos, but it went on to heal well. I discussed with my friends there. So conclusion, femur shaft fractures are very common in children. What we discussed here was treatment based on the age group. However, it is important to look at also the fracture morphology and decide on the type of treatment that's going to be offered. Do not overtreat. We have seen cases from peripheries or other hospitals where a tensional has been done for a 2-year-old or maybe 1.5 years old. So these would initially, if treated conserved in a spica cast, would do well, equally well, and child does not have to undergo under the knife. So and do not undertreat. If you see that there is a varus of more than 30-40 degrees and you think that no, just conserve it and nothing else is required, it would cause further problems, because that much amount of varus would never remodel one. Second, it would cause further chances of fractures because of abnormal loading. So in short, about today's talk, we discussed at different age groups. So infant, Paulic harness works well. Strapping is a good option. Still can be used where Paulic harness is difficult to get hold on to. Toddler fracture, spica cast works well. What I learned from very senior surgeons around here in Mumbai was, when I recommend spica cast, they tell me, why can't you just do a Thomas splint and put a cast over it? That also can be done. It's also a age-old technique. However, spica cast is comfortable, easy to carry. Child is, even parents are pretty comfortable in this thing. A young child of more than 6 years old and less than adolescent age group, tense nailing, submuscular plate, hybrid fixation we saw in unstable fractures. Sometimes conservative management can also be done in undisplaced fractures. And in adolescent age group, as we discussed, plating, adolescent femur nail or intramedullary nail can also be done, because now the physis is about to close and we can very well enter through the greater trochanter. So, thank you very much.
Thank you so much, sir.
Yes, so Chinmay, let's go on to Ashfaq's talk about technique, and then we'll take question answers.
Sure, sir. I'll ask Dr. Kaisar to introduce Dr. Ashfaq.
Please.
Yes.
Good morning again, everyone. Let me introduce you to Dr. Mohammad Ashfaqur Rahman. He is currently working in government hospital and ties with many private hospitals in Dhaka. He's working as a pediatric orthopedic surgeon for more than 6 years in Bangladesh. He is also so today his talk will be on surgical technique of TENS in fracture shaft of femur. I would like to request Dr. Ashfaq to share his screen and start his talk, please.
Thank you, Kasurabi. Thank you, Molin sir, for giving me the opportunity to be presented here. Okay, I'm now sharing my screen.
So I wish all the young trainees to pay attention. I learned this, I heard this talk at OSBICon and it's wonderful. So yeah, Ashfaq, please go ahead.
Yeah, thank you, sir. The last time, 9th OSBICon 2023 was a nice one. I have enjoyed a lot with Dr. Molin sir and Dr. Alaric sir. I'm presenting titanium elastic nailing in fracture shaft of femur of children. The systems how to nail the femur, fracture femur. The Alaric sir was injured a lot here last time, and as well as Valencia sir. So titanium elastic nailing, it is a minimally invasive, minimally traumatizing, and stable under movement and partial load bearing, and biological and child-friendly osteosynthesis. There are some properties of the nail. The different diameters of nail is available according to the medullary cavity of the bones. Tip of the nail is bent according to their diameter. This makes the entry of the entry to the bone and the opposite cortex. It can slide to the opposite cortex, and it also indirectly reduce the fracture. Biomechanics prevent elastic nail when inserted in fractured bone angles to the towards its apex. So it also retains its memory. So if we give the second rod matched diameter, same diameter, and curved is insert in which balances the first rod and equal but opposite moment. The two intermediary nails act as complementary to stabilize the fracture. And this is the biomechanics. This gives the axial stability, translational stability, and as well as the rotational stability. The procedures of the titanium elastic nailing, we need to some special instruments for that, like nail holder, nail bender, reduction tool, nail extractor, vice grips, and a nail impactor, and other things. We are familiar with that, drill bit, drill guide, F-tool, and nail cutter, sharp awl, cannulated awl. Now positions and draping. The placement positions may be placed either a fracture table or a reduction table. Surgeons have to move around. So legs, especially the contralateral legs, is abducted to allow the surgeon to stand on the medial as well as the lateral side of the leg. The limb is prepared and wrapped to give access to the entire femur and knee joint to permit manual manipulation of the thigh. The image intensified is placed so that the one can get anterior-posterior view and lateral view of the femoral shaft. The monitor is placed in such a way that surgeon can have easy vision when inserting the nail and reducing the fracture. Nail entry point. The selection of the insertion point of the nail is important. It is usually the medial and lateral at the top of the flare, the distal fascial plate, 1 to 2 centimeter proximal to the distal fascial plate, and they will tend to bind against the flare of the condyle. And always remember that the incision will be the lower to the entry point, so that when the remaining part of the nail is tend to blind against the flare of the condyle, it will no harm to the skin. If the nail started too low, they will tend back out, which can be a troublesome complication. In addition, the insertion should be posterior to the mid-lateral line so that if the nails back out, they will be less likely to enter the synovial pouch. I usually like to take the end-on view in perfect lateral position in C-on view. So if I go through by drilling by KOR, then I love to do that end on view. So it will be positioned in the central. So no cortical breakdown will occur then. In step 2, nail entry point, I've already decided where to entry the nail, and always put the awal first in vertically, so it cannot be slip out. Then after crossing just the cortex, then I will incline it and go towards the opposite cortex and more than 45-degree incline or to the flare. In the meantime, assistant can measure the titanoising nail, where should be the apex, where is the fracture site. It can be bended, it should be bended at that side. So ideally, the lateral nail should extend to the level of the greater trochanter and the medial nail into the femoral nail. The level of the fracture when nails are inserted is marked on the nails by placing the nail on the thigh, so that the tip reaches the level of the top lesser trochanter, and nails should be pre-bent at this level to make a gentle C. The amount of bending should be 3 times to the inner diameter of the shaft. Rules of bending. Apex at the fracture site, I have to put and check by the CM. Nail diameter is 0.4 into canal diameter. Both nail will be the same diameter. Symmetrical bending of both, gentle C shape. Symmetrical maximum cortical contact I can found for that. Amount of bending 3 times to the canal diameter. Both the nails are inserted through the entry points one after another, not both together. Driven up and go driven up to the fracture, then stop. Perfect reduction to be occurred. Then if one nail goes through the fracture line, then we will proceed the other nail. F tool is usually needed for reduction sometimes. By rotating the nail, further reduction of the fracture can be accomplished, and the second nail is unpassed. Already told that. After passing to the fracture line, traction is released. Then I will go to the up to the lesser trochanter, medial side, and medial side up to the neck, and lateral side up to the greater trochanter. And for cutting, always I have already told that I will cut at the site that nail will not be remaining nail will not be the hangover by the skin, so skin irritation will be less. Sometimes we usually push the tense nail a little bit, then impact after cutting, so that it will be merged with the flare of the condyle. The wound is closed in layers and dressing applied. Postoperative protocol: only transverse fracture, patient able to stand and bear partial weight. Otherwise, we will wait for 3 to 4 weeks. Use an enigmatic overview at a glance. Bended nail glide to the opposite cortex. Second nail inserted up to the fracture line. If reduction well, then go both nail. Then further insertion for not to irritate the skin. And you can use cap. This patient, Ashik, 11 years old, preoperative X-ray is there, and after 2 months of titanoising nailing system, The another patient, Mahin, 10 years of age, is the preoperative X-ray. After 6 months, another patient, Master Tawak, 7 years of age, is the pre and postoperative X-ray. Thank you all, and request to visit our country. Thank you, international faculty. And this is the another case I'd like to show. Thank you.
So thanks, Ashfaq, for that wonderful talk. Chinmay and Kaiser, now we can take questions.
Yes, sir. We have some questions from the participants. So first question is by Dr. Jones, that any tips for traction in children too small for a fracture table?
Yeah, so I'll tell, we had customized our fracture table to accommodate the short size. James, we can do that. You will see when you visit us. But still sometimes the child size is not appropriate, and then you can do surgery on radiolucent table. And any other comment? Yeah, so that's the way we should work on it.
Yes, sir. The next question by Dr. Anil Agrawal, sir. Will you please describe the Tobruk cast in a further detail?
Yeah, so Tobruk cast is basically what I've never done it myself, but yeah, I've seen it been done here in government hospital. So a small Thomas splint. So let's say we have a kid of about 3 or 4 years of age with a mid-shaft femur fracture. So what is done is a Thomas splint is applied with good padding and a good well-fitting Thomas splint, not of adult size, but a pediatric size Thomas splint with good padding. After when the traction is given in the Thomas splint, the fixed skin traction, when it is given in Thomas splint, the fracture fragments will align because the rest of the biology is preserved. We take a check X-ray in the Thomas splint, see that there is no varus or valgus and it is aligned well. Over the same Thomas splint which is applied, they roll over a plaster. So they roll a POP over the Thomas splint just to keep the alignment maintained for 3 weeks. Once the soft callus is seen, everything is removed and the child is allowed to be mobilized. So this is what they have done. I have not done it myself, so I don't have any picture of it. But our seniors here, surgeons who are almost 60, 65 years old, they have, when I presented my spica cast, they recommended, why don't you just do a Tobruk cast? And they showed their results, and it was pretty much of the same, like how a conservative management would work for these kids.
Yeah, so there are a lot of things were done. The children were within the this Thomas splint. They are recumbent. What they don't show is the complications which they have come across, like pressure sores and other stuff, the skin conditions. So our job is to try and bring the latest things, and minimize the complications and discomfort to the patient and parents. So maybe Meet will show. Now we have devised this hip spica stroller, and we make all the patients of either DDH or fracture upright on the same day of surgery in a stroller. So their confidence is also increasing, and they are very comfortable even with spica. We should not be shy of applying hip spica, because we manage all DDHs with it. Yeah. Fine. Any other question, Chinmay?
Yes, sir.
Someone asked about the adolescent femur nail, which companies provides it. So if you are specifically asking for adolescent femur nail, where the angulation is going all the way to the lateral cortex of the greater trochanter, it is available by Synthes and Smith & Nephew. Those are the ones which are R&D proved and very well fitting nails. But
So-
if you have a kid who is near maturity or the greater trochanteric phase is almost about to fuse, we can use humerus nail because the diameter of the shaft may be still narrow, maybe 8 or 9 millimeters. So those nails are available in humerus nails. So we have used them, and they also work well.
So the difference between this humerus nail and the typical trochanteric antenail is the mediolateral angle of the proximal fragment in trochanteric antenail is about 12 to 15 degrees, which makes it amenable to use even though you start little lateral on the tip of GTA. And in humerus nail, it is about 5 degrees. So that's the one, that is the change we want to make in the prototype nails. And humerus nails length is an issue because all adolescents have longer length. We can use them in OI and fibrous dysplasia where they have shorter femur length. But an adolescent with normal length, again, humerus nail would be shorter. So the cost of the Smith and Nephew and those nails are bit high, but are all local companies have started making it the prototype. So it would come in market very soon.
So if the diameter of the canal allows us to use more than 9 mm nail, then a routine greater trochanteric antenail would do well.
Yes, agree.
Yes.
All right. So do we have further questions, Chinmay, Kaisar?
No, sir. We don't have any further
Yeah.
questions.
So
Sure.
one suggestion, about cutting the neck nail. Ashfaq mentioned that we cut the nail and then impact. At times, it becomes difficult because the nail would bend, would turn while you push it. So one way is to drive the nail to the destination first, then mark exactly where you want to cut. One can do it with the serrations of artery forceps, or I'm planning to make an instrument with a pointed tip at an artery forceps with pointed tip. So you hold it very firmly and it will make marks. And then you withdraw that nail a little bit and cut it with the jumbo cutter. And so now you know from where you have to cut. And as you already have made the track of nail, when you push it with a punch and hammer, it will take the same path and it will not change the rotation. So that is one suggestion I have to make while you push the nail, cut and push the nail. So if there's no question, Chintan, that was a great talk. Let's go to the case discussion. And Goda,
Yes, sir.
can you share your case?
Yes, sir.
This case highlights the importance of proper nailing technique. If you don't follow proper nailing technique, then you may see such complications.
So, are you able to see the screen, sir?
Yes.
Yes.
A 14-year-old boy, he sustained a distal shaft femur fracture, and this was operated elsewhere. So
let's Goda, let's stop here and inquire that what people would like to do at the outset. Chintan, what would you do for this sort of fracture? 14 years old.
The fracture site is very metaphyseal.
Yeah.
Close to distal end. Bridging plate would work well. A locking bridging plate would work well. If at all a tensional has to be done, then it has to be from a proximal entry because distal entry will be very close to the fracture site.
This boy was 60 kgs, and one point you should have mentioned in your talk is more than 50 kg is the tens may fail because it may not hold the.
Yes, sir. So I mentioned less than 50 degrees we use tens. Less than 50 kg.
So this child was 60 kg. So
it is out of option.
So bridging plate is an option. Shalin, what would you do?
Yes, sir. So plate would be
plating.
Plating.
Anyone else who would do something different? Kaisar, Sujit,
I can try
Shamal?
nailing. It's
Mhm.
14 years already. You can use trochanteric entry nail or routine
Okay.
nail.
Yeah, and you would have 2 locking screws distally, yeah?
Yes.
Yeah, that's right. So you might see the distal fragment is quite funneled and wide. So you may have to use your polar screw or wire to have proper position of your nail in the distal fragment, but that is an option. Yeah, Goda, show what the primary surgeon did for this.
So it was operated elsewhere. The primary surgeon has done endus nailing. He opened the fracture, has done an endus nailing, and most probably he was not able to achieve good reduction. So he did an interfragmentary screw as well. So this radiograph shows the nails as well as the interfract screw along with the washer.
So I will like to ask Ashfaq, go back to the slide. Ashfaq, do you think all the principles of intramedullary nailing has been followed, or what things have been violated here?
Sorry, it is not followed. Unilateral sided nail was given. So memory will always put to the lateral side. So it will not be a well decision, I think so.
So these are the Ender's nails, and Ender's nails they work on the property of medullary jamming, medullary canal jamming. So its elastic property is not as good as titanium.
Yes, sir.
And even though you want to jam the canal, you see surgeon probably tried to introduce a nail from the medial side, but he probably have failed.
Yes, sir, there is a groove there.
There's a groove. So he chose to put nail from the top. And then it must be an unstable or translating fracture. So he has put a screw between the nails, thinking that that screw will keep the fragments compressed, but there's an adolescent bones and there are lots of forces. So all the rules of even Ender's nails and have been violated. If you want to put a nail from top, it should be shaped as an S shape, so that this one of the nail goes on the medial side. There is a flare of nails. So yeah, Godha, show what happened.
So it's finally started to collapse. This is 1 month post surgery, the radiographs, serial radiographs. And finally, the nail must have backed out and the surgeon removed the Ender's nail. These radiographs are 2 months post surgery. And this is 4 months post surgery. This was when the patient presented to us. He had pain at the fracture site. There was varus deformity. I'll share the video.
So
this was his
Chintan, yeah. So I think he has antalgic gait, and so Chintan, what would you do now? Goda, can you just show the X-rays, please?
Yes.
He's 14 and seems like there's some growth remaining. The physes are open. So Chintan, how would you manage this?
So, and there is already some healing which is seen. So this could,
there's a
yeah,
hypertrophic non-union kind of situation.
so we'll remove the screw, correct the deformity, and put a plate, lateral plate. Will
Right. What sort of plate you would use?
distal femur lateral locking plate above the physis.
Yeah, that's a good choice. Now this case I think I did before in 2009-10. So at that time this distal plates were not available. Yeah, but there is one more option we had at that time. You can also use Fellows and distal femoral locking plates also. They are good options. You might need to use a bit longer plate here to have a better working length. Any other choice, Kaisar?
No, at this point, I would also advise for lateral plating, but yet nailing is also an option at this point.
Yeah, that's right. Yeah, Goda, show what we have done.
So we have used distal tibial locking plates, and we have opened the fracture, removed the screw and fixed it properly, gave a stable reduction. And this is these are the follow-up pictures of the patient. The deformity is corrected. He's able to bear weight. There's no pain now. It went on to unite well, and this is 11 years follow-up. And this is his gait now.
So this fellow is working as a bank manager somewhere now in Saurashtra. So we use the lateral distal anatomic tibial locking plate because that matches the flare of the distal lateral femur above the physis. So, and the problem with this is there are 3.5 screws. They are not big screws. So for an adolescent, you are worried because you are relying on multiple small screws rather than a few big screws. But now with the advent of this distal femoral locking plate, which we use in cerebral palsy also, we can use those plates. So, so whenever doing nailing is not a problem, but all the principles should be well followed. That's a message from this. We have a few minutes. Meet, could you find that Spica Stoller video?
Sir, yes, I made a small presentation for it. Shall I share my screen?
Yeah, please. So Meet will share that how we can make the life of children easier with when we apply Spica. And yeah, Meet, please share your screen.
Yes.
Meet wanted to present a case which was in length unstable fracture, which already Chintan has shown, so it's no point in showing it again.
Okay, so this is just what we use for patients who have been given a hip spica. So the patient on the left was a case of shaft femur, and on the right was DDH. So as we can see, they are seated comfortably on the on this stroller that we have designed, and there's a 5-point harness over the chest that you can see, which keeps them in place. They usually require an attendant who is just behind the stroller, and they can move around comfortably with it. So a lot of times the mobility that we provide to the patient makes their life much easier, and it's quite easy also for the parents to manage the child with the spica on.
There are 4 wheels, which prevents sidewise toppling, and there is a front rubber stopper, so it cannot topple in the front also. And we have Meet will show you the design.
And if we can see there are these 2 rods at the bottom which hold the spica in place. And so this is the stroller that we have used, and for the spica table that was discussed that we use currently. One second. So this is how a spica table is. This is the spica table that we use, and we have a detachable acrylic sheet on the top, the white structure, and then we have this metallic base beneath it. It has 3 pillars attached, and as we can see, the acrylic sheet is detachable. On the right is how we mount the patient over the acrylic sheet. The head end of the patient is on the broad end of the acrylic sheet. And once we have applied the spica, then the acrylic sheet can just be detached, as we can see in this image, and it is slided out from behind the patient.
So the advantages of this table is multifold. This is a very lightweight and very easy to carry. We have taken this to our mission trips, so it's very easy to carry. Second thing, for young children, the torso is so well supported above that it makes easy for hold the patient there. The third thing is there is a lot of space underneath. So the person is applying spica, there is a free space. When we use this wooden bar, only the head and proximal trunk is supported. Here the whole body is supported. Thirdly, when we remove the acrylic sheet, it leaves behind a lot of space in front of abdomen. And so we don't need to make a separate abdominal window to prevent this mesenteric artery syndrome. We have written up a technical note on this spica table, and it will be published soon. For the spica stroller design, it is already published in Indian Journal of Orthopedics. We gave that spica as a hospital loaner program. So we have such 5-6 spica strollers in-house. And we give it to the patients every time, and then on a loan. And when they come back, they just pay the rent. And that can be given to other patients. So it's and our Sriji Orthopedics are the vendors who are making this spica stroller. So those who are doing a lot of hip surgeries, DDHs, sharp femur, I would suggest to purchase this. Cost is not much. Purchase a few strollers. We have the highest weight which it can carry is more than 50 kilograms. And this will make the life very easy for the family, because child will remain upright. They don't have respiratory things. Their mobility is good. Parents do not have to hold the child. And, now we are seeing extended benefits of this. Some families are asking, sir, please give us for some more time, because our child, they can do their motion and toilet when they're upright, and they were just putting a bucket. So it was very easy to clean their perineum. Of course, that was not the thought behind making this stroller, but different advantages. Our job is to make the surgeon's life easy while applying the spica. So we have devised this spica table. We have been using this for last, say 16 years, and more than 300 patients we have applied this spica on. And the stroller we have been using for all our patients. So we can send you the paper of this and the number of vendor, and he will courier it to you, and you can use and reuse it on a loaner program for your patients. Any questions about this? It can be answered. Yeah, and if we don't have a question, then we will conclude the meeting, and we'll answer those later on this WhatsApp group. Okay.
Yes, sure.
So thank you very much, everyone. Thanks, Chintan and Ashfaq, for those lovely talks, and I'm sure that will be of great help. This will be telecasted on Ortho TV as well as on our YouTube channel. So those who have missed, they can see it there. Okay. Take care. Have a good day.
Thank you, sir. Thank you, sir.
Thanks, Chintan. Bye-bye.
Thank you, everyone.